Well, I think I'm going to go ahead and start jumping into this. Welcome, welcome, everyone. I'm Karen Tripp, for if there's any new faces in the crowd, but I am delighted tonight to be able to spend a little bit of time talking about some of the springtime plans we have for Cancer Companions, and then I have a wonderful guest that I'm going to share with you guys. But first, I'm going to take a few minutes to show you some cool things that are out on the website. So let's see if I can get out there for a second. All right. Big news is talking about Take a Hike from Cancer. So Take a Hike from Cancer is going to be June 4th through 10th. Let me scroll down so you can see it. Our page is up and live on the website. There'll be a slider going up on the homepage tonight. And that's the same video from last year, but if you haven't had a chance to see it, I really encourage you guys to do it. We're really focusing on promoting prevention this year. The idea is that moderate, consistent exercise can lower your risk of cancer. And so that pretty much is something pretty significant information for, I think, just about everybody on the planet to know. And I don't really think it is understood that there are things that we can do just in terms of basic lifestyle things to be able to make an impact on cancer. I think we're becoming more attuned to being able to get our testing done sooner. And I think that's a wonderful goals to be able to have. But I really would love to be able to see as a nation, as a community, as a church, for people to be able to make an impact and say, hey, wouldn't it be awesome to be able to recognize that we need consistent exercise in our life to lower our risk of cancer. So what are we going to do? June 4th through 10th, we're going to go ahead and ask people to say how much are you going to walk that week. Are you going to walk 2 times a week, 3 times, 4 or more? And to pledge, that's how much we're going to walk that week. But in the meantime, we're going to find as many creative ways to get the word out to people that we possibly can. And so some of the things that we're going to be doing this year, well, let me ask you this. How many of you have ever heard of the Ice Bucket Challenge? So if you've ever heard of the Ice Bucket Challenge, type the word yes in onto my little boxes down there. So who's ever heard of the Ice Bucket Challenge? Okay. And so now, out of those of you who were typing in that you've heard of the Ice Bucket Challenges, how many of you either watched one of those videos of an Ice Bucket Challenge, or you ended up doing one yourself? Exactly. Lots of people know about it and stuff. And so we, of course, being a little bit of goofy people, since we're all Cancer Companions, is we decided to be able to watch to see if we couldn't get something similar to an Ice Bucket Challenge going around here. And so you see down here at the bottom of this page, and you should notice up here in my search column, if you guys look up here in the top right, you can see what I typed in was Take a Hike from Cancer. I have bought takeahikefromcancer.com. Plus, at this stage of the game, Take a Hike from Cancer, if you type that into Google, it will take you directly to one of our hike pages. And so this is our main page that's on our website. You can see it's cancer-companion.org/take-a-hike. And down here, there's opportunities for you to be able to register as an individual. If you just want to pledge for yourself, this is how much I want to, or you'd like to get a team of people. You know, I think this is such a wonderful opportunity to be able to get other people that you sit around and you think, you know, they should be exercising more. They really should be finding a habit in their life to be able to make an impact on their bodies more and their health. And this is a great way to motivate them to do that. The reason why we're a week-long walk instead of just a Saturday morning is because we want people to be able to start to see this as being a habit. Can we put the Take a Hike video link on our church newsletter? Absolutely. Please do. Put it on the church newsletter, stick it on your Facebook pages, Instagram, anywhere that you would like. The more you share it, the better. We would really appreciate that. So let me keep rolling. So you could end up registering those. Last time, for those of you guys that were here last month, I talked about being able to do sign-up sheets. We had a couple of different churches around the country that what they did was for 2 or 3 Sundays before the hike, they put a poster up in their church, narthex, and asked people to set a goal for how much they were going to walk for the week June 4th through 10th. And some of them said they're going to walk 2 times, some 3 times, some 4 times. And then what they did is on this following Sunday, because June 11th, the day after we're done, is a Sunday, they ended up having people come in, and if they completed their goals, they got a little gold star put next to their names. And you know what you can do after that then, guys? You can actually total up how many hours the people in your church walked to be able to take a hike from cancer, to be able to lower their risk of cancer. Wouldn't that be cool? Kelly, can you come take this call, sweetie? So, let's keep going down here. If you go down at the bottom of this page, like I was saying, we've been trying to figure out ways to get some excitement of people outside of the cancer community, outside of cancer companion community, or even outside of your churches to be able to get involved. So how are we going to do that? Well, like I said, we're going to try to do something that's kind of like an ice bucket challenge. And so in doing that, okay, we want to be able to have little videos that are going to be kind of like this. I'm just going to show this rather than explain it to you. So take a listen to this.
Can't hear it.
Sorry, those of you guys that couldn't hear. Let me try mine. I think mine's a little louder just because I'm a little louder. Here's another one.
Everybody should take a hike to reduce their risk of cancer. I'm taking a hike June 4th through 10th, and I'm challenging Kelly Corday and Clayton Jones to take a hike too.
Oh, maybe.
This is the way I take a hike from cancer.
It's the shoes, guys. It's all about the shoes.
That's great.
Okay. So that is kind of what I wanted to make sure I got a chance to talk a little bit about. We are going to be doing videos like this and challenging one another, and I would love to have as many of you guys engage as possible. We're trying to be able to put together a montage of some of these over the next couple of weeks if you want to do yours early. But the idea is that we don't want people to post these until May. So we're looking for May 15th. My goal is to have 50 people release all of their videos on social media all at the same time on May 15th. And so please think about doing this. I would love for you guys to be able to start some competitions within your own churches. Maybe it's the men's Bible study against the ladies' Bible study, or the youth against the church staff, or the choir against the worship team, or some of those kind of things. It would really be a lot of fun and such an energy of being able to get people to focus on being able to improve their exercises.
Yeah.
So, all right. So that is a little bit of what that is about. So any questions about the hike, take a hike from cancer, or anything going on with that? Anybody like to throw out at me? I love some of these ideas that you guys are putting down there about being able to do in memoriams and things like that. I think that's really special. So please think about ways to engage it. And if you do these events, guys, please let me know, because part of what we're doing by getting this out on social media is attracting attention to our website. So what I'd like to do is to be able to put events and things that are happening around the country on our events page, so that if somebody is in North Carolina and they're in the Raleigh area and they see Take a Hike from Cancer and it looks great, but they don't want to walk by themselves, they could actually go out and see what churches are participating that they could engage with. And so that's part of what some of the ideas are too. So stay in touch with me. I'll be staying in touch with you, and we'll see what the Lord's got in mind this year. Okay? Awesome. Okay. Time for some introductions. I am thrilled and excited that we have Dr. John Gazak here to be able to help us to understand what I think is a very misunderstood or unknown portion of medical care. Palliative care is an essential piece of being able to help people care when receive medical care when they're going through difficult times. And I think a lot of times people don't even know that the resources are available. I'm amazed at how often insurance is excited about the opportunity to provide this type of care. And so it's something that I think people are not looking into as much as they need to. And with the way that cancer treatment has become more and more and more long-term, I think it's really important for us to be able to take a look at this as well. So let me introduce and get off of here so that you can end up hearing what all we have to say tonight.
Greetings, everyone. My name is John Gazak. I am a hospice physician, primarily at the Hospice of Iredell County, which includes Statesville, North Carolina, Mooresville, and all environs in between. We're just north of Charlotte, North Carolina. This is my 6th year in hospice. I was a pediatric urologist in my first life, as I like to say. But this has been probably the most rewarding part of my career. I appreciate the opportunity to be able to speak with you. I think your organization is doing wonderful things, and I admire all of you for taking your evening to listen to me. I tried to get my kids to listen to me for 18 years each, and it didn't always work so well, but thank you for being here anyway. I will admit from the very outset that in our organization, we have one doctor that does primarily palliative care, and he has a medical social worker who works with him. The best way, I think, to understand the difference between palliative care and hospice is that Medicare feels that palliative care involves a patient who has a terminal diagnosis. It could be end-stage heart disease, COPD, cancer, or one of our biggest growing areas, dementia. But their prognosis is at this point greater than 6 months based on our assessment. The hospice diagnosis is when you have that same illness, but your prognosis is less than 6 months. One of the biggest problems hospice runs into is many times our referrals come a day or two before the patient's death, so we really don't have an opportunity to do much for them. So usually the palliative team is relatively small. It is generally not covered much by insurance, but what we do is we can provide a little more care, for example, than a very, very busy oncologist or cardiologist can. And they will call us and say, I've run out of medicine, and certainly we can prescribe medicine for them. If they say, I'm too sick to go out to see the doctor and I think I have the flu, we can go out and see them under those circumstances, and if necessary, prescribe something as well. And the social worker and nurse can help with doing other things. Whereas hospice, our hospice teams are much larger. When someone signs up for hospice, they have exposure to a chaplain, to a nurse, to a CNA, to a social worker, and to a physician. And all of them can be very actively involved depending upon the patient's needs. So, and what we do is every week we have what's called it's kind of an in-service where we get together and discuss all the patients, and anyone that has an issue can speak. So usually we open with the social workers giving their reports, the nurses give their reports, and then the nurses and the social workers, if they have questions of the physicians, they can go ahead and do that, or they can ask questions about the theological issues that the patients may be facing. It's very important, and I think hospice really makes a big effort to understand that there are many components. For example, pain. There's an entity called total pain. which means it's not just physical pain, it's pain that's potentially social, it's theological, it can be psychiatric. So we try to delve into all those areas, whereas, realistically, a cardiologist doesn't have time to discuss the fact that your daughter is struggling with substance abuse and what can you do to help her. So I think that our organization kind of fills in the weak areas of care that often present under these circumstances. Now, one of the best things about palliative, besides having this access to additional care and people coming to your home or to your facility to see you, not having to necessarily go to an office, although many palliative care organizations will have offices that the patients can go to. A lot of times it just makes life so much easier for them if they don't have to get packed up in the car and taken, especially if they have difficulty walking, especially our elderly population. So, and of course, many of our patients are in that group. Let's see what else I want to say here. Cancer and palliative care. A couple questions that are listed here ask about, can you talk to the oncologist and so forth. The reality is that the oncologist is the referring doctor. And if someone asks me a question about their cancer care, my first thought is to say, you need to talk to your oncologist or your oncologist nurse, because they're the boss. And if I say something that goes against what they tell you, they're not going to like me very much. And I'm going to be soon retiring. So I think that's important. We don't want to step on any toes. So generally with cancer patients in particular, we get called in when the oncologist says there's nothing more I can offer, or if the patient says, I can't take any more of that chemotherapy or that radiation, I can't make the trip to your office once a week because I'm too weak. Because as hospice doctors, we can go to the house, our nurses go to the house, and the patients really never have to leave the home if they're not able to do so. One of the things to remember about hospice is there is a great misunderstanding. One of the funniest comments I hear from family members generally is, well, I know somebody who got involved with hospice and they died. Well, that's what we do. We take care of patients that are dying. And oftentimes they're dying very, very quickly. But our job is to provide continued palliation, but under our visage, Medicare will cover most things that we do. They will cover certain medications, although we do have formularies that we need to use, and that we can expect Medicare will reimburse most of those things. It used to be that we only would be reimbursed for things that were related to the primary diagnosis, but as you well know, most people in their 50s and 60s in these countries have a grocery list of diagnoses: diabetes, hypertension, hypothyroidism, on and on and on, heart disease, liver disease, kidney disease, and so forth. So we now will cover most of those drugs, even insulin, things like that, that get a little more expensive, but it's just part of our job because it's very important to us. What we usually try to reassure patients and families that our job is to keep them as comfortable as possible, as long as possible, okay? When we walk in and this actually happens, the patient says to me, did you bring the shot today? And I'll say, I don't give shots. And he said, I mean the one that's going to put me down. Well, no, we don't do that. That's illegal in North Carolina and most other states as well, at least at the present time. So there's a lot of misunderstanding. So one of our biggest jobs when we see patients under those circumstances is to say, listen, do you have questions? Let us tell you what hospice does and what hospice doesn't do. And understand that we make recommendations, we don't make demands. So if you say, I'm not going to take morphine. I'm not going to give it to you. Why waste my time and yours? Why waste Medicare's money? But when you're in a lot of pain, that's the drug of choice. It's also the drug of choice, for example, for dyspnea, for shortness of breath. So all these things are, I think, very important. And it's very important to give the patients an opportunity to go over things that they're most concerned about. One of the other issues that we like to cover very, very regularly is to ask them what they understand about their disease. What do you understand about your disease process? And it's amazing how many patients, regardless of the disease process, don't have any idea. When I tell a patient that you have a cancer and that this cancer is going to be your cause of death eventually, and what we need to do is do everything we can to make you as comfortable and as functional as possible. And they'll say, nobody ever told me that. Well, it's easy to assume that people know if they have cancer, if they have, quote, end-stage heart disease, lung disease, liver disease, that it's going to be the cause of their death. But you need to at least give them an opportunity to pursue that with you. And working with these patients in your support groups, I suspect you're going to have patients who fall into that area and will say, well, what does it mean, that I have metastases? Or why is it that I have lung cancer and most of my pain is in my back or in my rib because of metastatic disease? They don't really understand that. And the oncologists are so busy, God bless them, that they don't really have a lot of time to discuss that. And a lot of patients don't understand the side effects of the drugs they're getting and that type of thing. So that's a thing we can do, and that's something that you can certainly do or bring to the attention of the nurses you work with or the organization you work with or the hospital you might work through to let them know that this patient really needs a little more counseling about what their disease process is. Okay. The other question that hospice gets all the time is how long? Okay, and that's an easy one because most patients that come to us will say, well, the doctor only gave me a week and a half and it took you 2 weeks to get out here and I still feel pretty good. Well, we don't like to predict. There is an old Yiddish saying that says men predict and God laughs. And when it comes to predicting time of death, I suspect God laughs very heartily because there really is no way to know. I can tell you about so many patients who I see when I first come into the building at the hospice house, and I say, my guess is they'll probably be gone within the week. And when I come back for my next rotation 3 weeks later, they're still there. Whereas the patient that looks fairly hardy but has a terminal disease may be gone in 2 days because the diseases tend to be very unpredictable. One of the fascinating things about hospice is when hospice first became popular in the US in the 70s, it was mostly cancer. I've been told 85% cancer. And now we are 45% dementia. And dementia, of course, is extremely unpredictable. I saw a patient the other day who had a bad bout of aspiration pneumonia, went to the hospital, was hospitalized, treated, and then came home. And they called hospice and said, this patient is hospice appropriate. And I went out to see the gentleman and his wife was so concerned because she felt like if they referred him to hospice, he must be dying. And I went upstairs and he was very unhappy with my visit because he was busy watching TV and finishing his lunch. And he had a conversation with me. He was oriented, he was alert, and he was eating well. He was still going up and down the steps. Bottom line was, he's very appropriate for palliative because he does have dementia, but it could be years before the dementia puts him into a position where he has less than 6 months to live. So that's a good thing for me, because then I can go and say the old good news, bad news. The bad news is your husband is not appropriate for hospice. That's the good news as well. And what we will do is step back and refer him to palliative so that they can still be with you, and they can contact us at the drop of a hat if anything should happen to your husband. He falls down the steps, he develops new problems, he develops seizures, his condition gets worse very quickly. And those are things that we can step in and help with right away. So it makes for a good marriage for them to have the continuation. But it's interesting that I read an article this weekend about palliative, and it was cardiologists that were talking about patients who are potential candidates for cardiac transplant. Well, they're very good candidates for palliative, but one of the cardiologists argued in the discussion that they talk people out of having cardiac transplants. We do no such thing, because if you have a cardiac transplant, you probably have a terminal condition. And even though you have the transplant, who knows when you may have a reversal of your situation. Maybe you're going to start to lose your heart's effectiveness. Maybe it's going to break down. Maybe you're going to have a problem with your body trying to get rid of the heart. So all those things come into play, and those are patients that ultimately usually end up with hospice. All right, physical symptoms. Our job is to take care of symptoms. So when new patients come in and I introduce myself and I examine them and I tell them, number one, I don't know you have a problem if you don't tell me. And I'm not going to say, I don't have time for this. Yeah, I do. And if you have a symptom, you need to tell the nurses or the CNA or me, because we can do something about most symptoms that you will have. I had a list here of the symptoms. For example, when people have pain, that's pretty obvious. We have lots of pain medicines, beginning with Tylenol and Motrin, all the way up to opiates and intravenous or sub-Q lines that pump hourly amounts of drug into patients who are having horrific pain. And the pain that patients have, one of the lessons I learned with hospice is when I was the pediatric urologist, we were always extraordinarily careful. I was literally religious about not overgoing the recommended doses of the pain medications, of the sedative medications, and so forth, not to produce any overdoses. And when I came to hospice, I realized that when I went to my first lecture on pain control in hospice, the nurse who was giving the talk said, okay, what is the definition of pain? And we all had these wonderful ideas and suggestions. And she said, pain is what the patient says it is. And that's really true. The amount of pain that some patients will suffer with all sorts of disease. I don't know if any of you are as old as I am, but I will tell you that I hurt, okay? I wake up in the morning, this joint is stiff, my neck is stiff, my back is stiff. It's normal. And I don't need any big pain medicine. But when I do, I will take something like diclofenac or naproxen, and it helps. So I don't need any big stuff. But the point is, you have to ask people, do you hurt? Even if they're a dementia patient, even if they're a heart patient, and so forth, because aging can cause lots of pain. You want to ask them, we ask them about other parts of their life. Do you have nausea? Are you eating well? Have you lost weight? And a lot of times it's surprising. People say, oh yeah, I forgot, I was going to mention that, but I didn't remember it. So listen to them, ask them if they have symptoms. Everybody that is on an opiate is constipated. And most people that are on opiates regularly, scheduled, are patients who eventually will need probably more opiate. So we don't use them unless we need them. And we often will start with lesser drugs, Ultram, Tramadol, so Toradol and so forth, that can be very, very effective drugs for relatively minor pain, not usually for cancer pain. For cancer pain, we usually will use Dilaudid, fentanyl patches, morphine, of course, and pick our drugs based on what we see going on. We follow the rule, start low and go up slow. And that's very, very good advice for anyone who's going to be taking care of patients, even the family. You know, we tell the family, we can give you medicines that can last 12 hours. We can give them medications that will work in 5 minutes. But if you take a regular tablet of hydrocodone, Lortab, that kind of thing, it's probably going to take 30 minutes before you get the effect. So if a patient all of a sudden screams out in acute pain, we have a liquid form of called Roxanol, which is liquid morphine, that placed in a small dropper under the tongue will produce very, very good pain control within about 5 minutes. I have a chat here. Yeah, well, palliative care, yes, we have patients stay in palliative care sometimes for quite a lengthy period of time. And, but within the same office, we'll get calls from the nurse or social worker, and they'll say, Dr. Frankenhauser said that we would like to switch this patient over to hospice. And I ask why, and generally there's a good reason for it. And that's when usually like a cancer patient, the oncologist says, I'm not going to manage your pain anymore because I can't seem to get the results we need. So I'm going to refer you to hospice. Or they say, I looked at your studies, you had your 3rd round of chemotherapy, the side effects are killing you, and your disease is progressing despite the best chemo we have to offer. Now, under those circumstances, they call hospice. So that's why I say, if a patient called me and said, listen, I'm not on hospice, I'm on palliative, but I'd like to be under hospice. What do I do? And I would tell them to ask their oncologist about it. And the oncologist will likely say, no, you're still my patient. And we don't have any problem with that. But we'll be available right away if we're asked to see the patient. Frequently what happens is these patients are admitted to the hospital for uncontrolled symptoms, nausea and vomiting, progressive weakness, which can be very, very profound. Profound weight loss, cachexia, where they become almost skeletal. And, you know, that's often when they'll make the switch. That happens because probably what happens is if you've known friends that have had cancer, a lot of times the internal cancers, liver, kidney, stomach, pancreas, gallbladder, colon, they don't push out like a big lump like you would get if you had an external tumor on a muscle or something of that sort, which you almost can't miss. And what happens is they present finally after they've lost 30 pounds that unfortunately they had no interest in losing. And unfortunately, that is generally evidence of a very, very severe undiagnosed condition. So if you know somebody that has lost weight and you say, wow, what diet are you on? You look like you're losing weight. Don't say they look great until you get a little more information. And they'll say, well, I really haven't been trying to lose weight. You know, I've been feeling kind of weak and run down. Well, that you need to tell them to get on the phone and call the doctor like now while you're with them, so you make sure they do it and make an appointment, because frequently that's the beginning of the end, so to speak. Okay. Anybody have any questions so far? I see somebody's typing. I'm going to move on to the morphine sheet because I think that's important. Keep my voice up. Okay, thank you. I will. Wow, nobody ever asked me to do that. Thanks. Thank you, Joy. Morphine. Will my body get used to morphine if I start now? If you use it regularly at the same dose and you have a disease which is going to progress, like cancer, okay, almost positively your pain will get worse with time. It's not because of the morphine, it's because of the disease progression. So there is a tendency to need more of the drug as time goes on, needless to say. If you keep them on what we call a PRN dose, which is as needed, and they only use it once or twice a week, once or twice a day, usually that's not a big deal. But again, most of these diseases will get worse, and it may or may not be associated with the patient having used too much or becoming more dependent. Is it potentially addictive? Yes, but understand that addiction is a mental health problem, and it's a physical health problem. It's like alcoholism. I mean, there's nothing wrong with having a social drink from time to time, but if you are driven to drink all day long and you start in the morning and end at bedtime, that's a health concern, and it's something that is an addiction and something that needs to be addressed and hopefully treated aggressively. Same thing with addiction. Patients with addictions usually don't have cancer. They often don't have physical pain. They often have mental pain, social pain, and so forth for one reason or another. But the bottom line is those patients will beg, borrow, and steal to get that medication. They are driven to get it. They will kill people to get it. Okay? The cancer patient isn't going to go out and worry about that if they're under hospice care, because they will get the pain they need taken care of. And usually it will require something like an opiate or that type of category. The other thing we use a great deal of is steroids. Not the steroids that got Alex Gonzalez in trouble, but corticosteroids. Dexamethasone is the drug that we like the most. The reason for that is dexamethasone does several things. In fact, it's often used in cancer protocols because, number one, it helps with pain because it's a tremendously strong anti-inflammatory drug. Obviously, it's used a lot for rheumatoid arthritis and things of that nature. And the other thing is it produces a sense of well-being, and it also stimulates appetite. I think it stimulates appetite better and safer than one of the other drugs that a lot of people use, and that's the, oh yeah, well, Marinol. Marinol doesn't work worth a flip, in my opinion. Megace, yeah, which is more of an estrogenic type hormone. It doesn't produce the pain relief, and it doesn't produce the sense of well-being, but it can definitely increase the appetite. It's pretty yucky to take, whereas the dexamethasone you can take as a pill or a few drops of liquid. So we particularly like that. It also is very useful in patients that have brain tumors, whether they are primary brain tumors or metastases, because it's one of the few drugs that will decrease the intracranial pressure, which can then help in terms of the headaches and the blurred vision and the confusion, seizures, and so forth. Okay, will it still be effective in the future? Yes, as long as you continue to adjust the dose if you need to. We did say it's addictive. Can I stop taking it if my pain goes away? Absolutely, positively. One of the other misconceptions is that we bring patients into the hospital for intractable pain, intractable nausea and vomiting, things of that nature. And it's not uncommon for us to actually send patients home or back to their facility, because the facility will call and say, listen, we just can't get this thing under control. Can you help? And that's when we often bring the patients to our hospice house. And at the hospice house, We will aggressively deal with their pain. And even if they're on a pump, we can often send them home with these pumps. And our nurses who go to the home 2 to 3 times a week can even go more often than that. And they will deal with these issues in that facility. Is my voice better? Joy will tell me in a minute. The other question here is, will it make me constipated? Absolutely. So one of the things we always do is we like to put patients on medication, and what we try to use is bulk medicines for this. You can take Miralax. We use Senna S is wonderful. It's a combination of Senecot and stool softener, and that works extremely well. But you have to be proactive. If you don't, then the patients will come in and they'll say, yeah, I don't think I've had a bowel movement for about a week or 10 days now. That's not so good. One of the problems is there are opiate receptors on our colons. And the good news is there are drugs out now which are injectables that can unblock those sites if you're constipated. But it's so much easier not to get there, because one of the first steps when patients get severely constipated is to do what we call manual disimpaction. Let me give you a hint. Manual means fingers, using your hands and fingers. So it's not a good way to make friends, even if you're a hospice nurse or a hospice doctor. And thank God the nurses generally take care of it. Very pleased with that. Are there other alternatives? Yeah, I wrote down a number: dilaudid methadone, steroids, tramadol, Ultram, NSAIDs, which is your, well, it's a lot of drugs. The ibuprofen, the Aleve is a good NSAID. It's actually a drug called naproxen, and it's a non-prescription strength drug. Naproxen is the prescription strength drug. So those are good, and they're particularly good for elderly patients with joint pain. The problem with NSAIDs is that they have a tendency to irritate your stomach and can lead to ulcers. So if I give somebody an NSAID for pain, especially joint pain, bone pain, and so forth, then what I'll do is I'll give them something like Prilosec, omeprazole, to take prophylactically to try to prevent any of that kind of problem. Let's see, I have that. And then we also, when patients get severe pain that really isn't getting better with our protocols, what we can do is we can still send them to the radiologist for palliative radiation. So if a patient has a big mass coming off of their face or neck or of their throat, we will send them to the radiation oncologist, and Medicare will cover that radiation therapy up to a point, which can make a huge difference. It's great for bone pain because of bone metastases. Tumors like lung tumors and particularly prostate cancer tend to go to the bone. Breast cancer will go to the bone. And the bone pain is severe and debilitating. Two of the drugs we like to use for that are methadone and steroids. And methadone is a very useful drug that is very complicated to use and not something that most physicians use in general, because it's one of those drugs that if you take it today, you're not going to get maximal effect for 5 days. So it's great, but you have to make sure patients understand that that means you don't take 2 extra ones tomorrow because that damn medicine he gave me isn't helping very much. They could end up being comatose in 4 days or 5 days. In fact, there was an article in the New York Times several years ago about there was an increase in methadone-related deaths in New York City among addicts who were put on methadone for one reason or another. It's usually used to help people come off of the disease, but it can also be used very effectively for pain. In fact, it's a great pain medicine. And we have had patients who are on 500, 800, 1,000 milligrams of morphine a day, honest, where we can switch over, rotate to methadone and reduce that by, who knows, maybe 50 milligrams a day. It's a drug that's not well understood, and it can be very dangerous in the wrong hands. But with hospice, it can make a huge difference with these patients. All right. Let me see what my next page talks about. There we go. We do have patients that we see, particularly with palliative, but also with hospice, who do want to go back to work. Nowadays, of course, many people can also work from home. And if a patient asks me if they can work from home, I tell them I'm thrilled if you can. You tell me if you can work from home, because you know the amount of effort it takes to get through a workday. And if you promise me you're not going to wear yourself out, do it as much as you'd like. The other question is, can you advise me on the timing of holidays and so forth? I will always encourage patients who I think can make a trip to take it, as long as they're not going to do it alone, as long as they're not going to make long drives themselves, but would be comfortable sitting in the back seat and make sure they take their medication. And what we try to do is, if they're going to go long distances and they want to have an extended stay, like we have patients, for example, that live in North Carolina and they go to Florida or to New England for the off season. So they go to New England in the summer and come to North Carolina in the winter. Well, what we do is we make arrangements through our social work and our nurses to contact the nearby hospice where they're going, and they can coordinate that. And as soon as they get up there, then their hospice will take over their care, and that will revert back to us when they decide to come home. So that works out very, very nicely. Even if they go to the beach, we usually try to set up a hospice patient, especially one who really has a lot of very serious ongoing problems and tends to be pretty demanding, having issues that come up often. Make sure they get connected with hospice, because going to the emergency room, the nice part about hospice is if we get a call at 3 o'clock this morning and we have a patient that says, I didn't break a bone, I didn't cut myself, but I feel really lousy, I'm having trouble breathing and so forth, we go out and see them in the home, even at 3 o'clock in the morning. Palliative will go out and see these patients as well when necessary. But usually it's the hospice nurse that will go out at night. I lost it.
Uh-oh.
I don't know.
It's all working.
Oh, we're back. I'm sorry. We blacked out. So anyway, I was emphasizing the fact that you can call hospice 24/7, 365 or 66 days a year. We work all holidays, and if you call, you will get a call back. It's not as fast as EMT, but remember, when you take a patient that's sick to the emergency room, they could sit for 4, 5, 6 hours, especially on a weekend night. And that's really not good quality of medical care, and certainly not good quality of life. Whereas we should be able to either advise them over the phone what to do, because we know what their medications are, and we know what their symptoms are once they describe them to us. And we encourage people to call us. Driving, it's a big problem, because nobody wants to stop driving, because that's kind of the opposite of the excitement of being able to drive for the first time when you're 15 or 16 years old. It's a tough decision to make, and people will go out and drive even if I tell them not to. But if they have seizures, if they're weak, if their legs don't work well, if they have blackout spells, if they are hypotensive, I tell them, if you go with somebody who can take over for you immediately, don't take your 8-year-old grandson with you. and you don't have any accidents, and you're not bumping into the wall of the garage when you try to park the car, you could go to the grocery store. That's it. Okay. No going to the beach. No going to the mountains. Sit in the back seat and be nice. Get an Audible book on tape and listen to that. And try to entertain yourself, but don't worry about the driving. You drove for a long time. This will help you. So, Karen, is that where we stop? I know you want to leave time for some discussion and questions. Okay.
Absolutely. This is wonderful. Thank you so much. Has anybody got any questions or comments or stories or anything they'd like to share? You hit on so many wonderful points. Looks like we've got some folks typing. We've got a couple of nurses in the crowd.
The nurse in the room said they just caused trouble. I don't believe that for a heartbeat.
Well, maybe that one
good
interrupted
point.
you, but, exactly. Well, excellent. I'm glad there's lots of good questions and comments. In this day and age, it's hard to find a family that hasn't experienced hospice, but maybe
Good
not.
point.
Okay, let's see.
Absolutely, I can see it.
Would that be helpful?
Very good question. Interesting is a lot of our patients will become what we call unresponsive, which is the term we usually use because, a lot of people don't realize that dementia is a terminal illness. So a lot of these patients will come to the house when the family says, I can't do anything. He's not responsive. He doesn't talk. He doesn't eat. So we bring them here. And believe it or not, you'll see that a lot of these patients have what we would consider nonverbal signs of pain, agitation, severe anxiety, trying to climb out of bed, yelling out at times, grimacing when you come in and move them. I saw a patient today who, when I walked in and put my stethoscope on his chest, he hollered out. Okay, the guy doesn't talk, but it was clear. I left my stethoscope away, waited a minute, tried again, same thing happened. Well, he was in pain, and I gave him pain medication, and he's doing great. Tonight he's eating. So it's these illnesses can have almost a sine wave configuration to them, where one day you say, "Oh, this is the end. Well, I got to tell the family, bring the family in." And the family gets there and they'll say, well, he's in there eating breakfast. What were you talking about? You said it was the end. So again, wise people don't predict much about dying and time of death and so forth, because it's a great way to get into trouble. Thank you, Joy. I appreciate that nice comment.
Also,
yeah, we give families education on those signs, because they'll call and they'll say, why is it that he calls out in the middle of the night? Well, if he's on, say, 4 times a day pain medicine, he may have gotten the pain medicine at 8 o'clock. He's calling out at 2 or 3, because a lot of those pain medicines, especially the tablets, only last 3 or 4 hours. So it's time for another tablet, and it's time to give it to them. Thanks, Carol. Anybody else?
What's the biggest challenge? Did you see the one that says, what is your biggest challenge in hospice?
I think the greatest challenge of hospice, to be honest with you, are families that, it's interesting that when I was a practicing physician, people used to say, the further you go for a second opinion, the more expert that doctor is going to be because it costs you so darn much time and effort and money to get there. And what we find is a lot of times family members who live the furthest away are the biggest experts because they may not have seen their parent for 5 years, but they know what's going on. And you need a better doctor. They're nuts. They shouldn't be giving that and that and that. We get this all the time. And then they come and they get the family here reared up and feeling very guilty and so forth. So that type of thing is difficult. There's an old saying that no good deed goes unpunished, and that frequently is the case. But it's such a rewarding area, and I think even the role you guys play in taking care of these patients and the things you can do to help them, I think the most important thing is to encourage them that hospice care is great. My father was very, very ill, and he had hepatitis C because of transfusions he received when I was in high school, which, you know, there were still dinosaurs around then. And he developed a real bad decline, and we took him to the hospital and they admitted him. It turned out he had a massive hepatoma, which with hepatitis C, and he also had colon cancer, that was not surprising. And I would walk in and he would be, you know, moving around in bed and very anxious and irritable. And I'd say, Dad, you're hurting. Can I get some pain medicine for you? No, I'm good. So I said to my mother, we need to call hospice. And we called hospice in, and this lovely young nurse walked in and walked up to him and said, John, are you hurting? And he said, I hurt all the time. So, you know, that's another thing. Sometimes it's easier to tell a stranger. You don't want to tell your child or your wife because you don't want to look weak. But it's nothing weak to be hurting. And when pain can be controlled, it needs to be done. The other thing to remember is when patients come to us, we continue to deal with their other medicine. So one of the things I find myself doing a lot is when patients get further along with many diseases, heart disease, lung disease, liver disease, cancer, dementia, is, for example, they come in and their blood pressure is 110/80. Well, it's too low. Okay, the new recommendations for patients 75 and older is 140 is perfectly fine, perfectly acceptable. They don't need hypertensive medications for that. A 20-year-old, of course. So it's very different because the perfusion is a little more difficult in somebody that has coronary atherosclerosis, cerebral atherosclerosis, and so forth.
All right. Well, this has been extraordinary. I just can't tell you what a blessing it's been. Thank you so much, John, for being here. And thank you, Sarah, for encouraging him and inviting him to join us. And if everybody will bow their heads for me, I will pray us out of here. And if anyone else still has any further questions, you're welcome to stay afterwards. Lord, I thank you. I thank you so much for every heart that's on this call. I ask you to just go before us, Lord. We each have our own tender spot of wanting to be able to reach into the lives of people coping with cancer and to bring them sweet relief through you, but also through the care that we can advocate for them to be able to get through the medical profession, because we know that you use those hands and those thoughts and those minds as well, Lord. And so just make this evident to us, make our path clear, and help us to walk your walk. In Jesus' name we pray. Amen. Thank you, sir, so very much. And thank you all you guys for being here this evening.
Thanks for your attention, gang. I appreciate it very much. It was a great opportunity, and who knows, maybe we'll get together and meet again sometime.
Well, we'll be here tomorrow evening, and if you know people that didn't make it tonight that would like to come and hear one, please have them join us. Thank you. We'll see you then.
Bye.
Bye-bye now.